so that part, which when we get to it, I'll tell you, that will be something that I can potentially test on as far as you knowing like where to put an ointment versus a cream versus a gel. So most of the time, that's the stuff that like I don't pay attention to for this lecture, because the way that you give a medication can change the area that it's going to. We will talk about that, and you will have questions potentially on that. All right, so we all know the skin, right? It is our big barrier. It's trying to protect us. We have our 3 layers, your epidermis, dermis, and your subcutaneous tissue. Within your epidermis, you have your sublayers, and when we think about the skin and when we think about derm and like anything that's topical, you're going to be having to get through this rate limiting step. You have to get through the skin, okay? So depending on different things that make up each person individually, you may see varying results or even a varying half-life from that patient. So again, this was just telling you the same thing that we just talked about, right? Different layers. This part I'm not testing you on. I'll tell you when we get to the stuff that I'm testing you on, okay? There's different layers, and so bless you, when we get to our corneum, which is right here, the thing that's on the, sorry, you don't see my paper. The most outer layer that we have of the epidermis, this would be us having our drug. Now your vehicle is used just to deliver the drug, okay? So your vehicle would be me saying that it's a cream, a lotion, an ointment, an oil, what have you. Then you have your drug that's going to be in that. So it needs the vehicle to drive it to the skin and drop it off, right? So in some situations, if I want something to stay in a place longer, or if it's a dry, thicker area, I might choose a different vehicle. So that's why we are going to talk a lot about the vehicle. So when you hear that, that's what it's saying. So the vehicle will get it to the skin and where it needs to go, right? And then it's going to have to get absorbed through the skin to get into the body, okay? So if I have thicker skin and you put something on, you think it's going to take longer for it to go through my skin or a shorter amount of time? Longer, right? If I'm really old, my skin is thin, what do you think is going to happen then, right? It's going to go faster. So thinking about like an older person, a baby with that nice soft skin that they have, right? And then us kind of in the middle, you're going to see different results with different things. So the strengths and the vehicles that you use are going to play the huge role. And then again, just understanding that that corneum is going to be your rate limiting step for things getting there. It's also going to hold things there sometimes longer or not as long, depending on that patient. So when we look at this, and when we look at you trying to choose the correct medication and also the correct vehicle, you have to make sure that you're observing that whole patient, and you're also seeing where the their issue is, okay? So looking at this, you see that your permeability will vary depending on where it is that somebody is having their issue. So if I have something on my face or in a very thin area, my growing area, the strength of different medications that you have to use in those areas are not going to be the same if I have something on the palm of my hands or my feet, because that's a thicker area. So when this is saying like different areas are going to say require different things, remember just this portion of it, because you're going to see this and it'll come up in our charts that we're going to talk about. And then looking at the fact that like you can see increase or decrease half-lives whenever you're talking about these medications, depending on how your patient presents. Because yes, my skin is holding it, right? It's the reservoir that's holding these medications. But again, like we just said, if I had thin skin versus thicker skin, I might see a difference in my half-life, right? The ability and the capability to be that rate-limiting step to get that medication in might be changed because the integrity of the skin is changed. If I had a cut and I'm putting something over a cut, now my barrier is completely gone, right? So the way that I'm absorbing that might be different. If I cover something, now I might be speeding up the absorption because now it's hot under there, and now I've increased how much my medication is getting absorbed, maybe faster than I wanted to. So paying attention to all of those things are very important. And a big rule that you'll see as we're going through here is if something is wet, you want to dry it, and if something is dry, you want to wet it. So what that means is if I have something like eczema, right, their skin is very dry. They're itching, and the more that they scratch, themselves, the thicker that that skin is going to become. So if I can wet it or moisturize it, then I'm going to help make that patient more comfortable. If I have something that is weeping and crusting over, making a lot of scabs, I don't want it to continue to weep because I'm also losing fluids and different things that I would like to keep in my body. So if I have something that's weeping, my goal is to dry it. Okay, I don't want to allow it to continue to weep. I want it to form that scab and heal. Okay, so if you just remember, if it's dry, wet it. If it's wet, dry it. That concept will go, especially when we're talking about some of that contact dermatitis. These are the different impacts that we will see as we continue to look at some of our meds that are topical. So when we're talking about derm, yes, there's a lot of topical things that we can use, but sometimes it does escalate to where you'll see a couple of oral meds as we go through this lecture also. So depending on where it is, right, your permeability is going to change because the thickness is changing in those areas. So the thinner something is, the more likely it's going to be absorbing more. The thicker something is, more likely for it to be absorbing less. On these slides that we're about to go through now, pay attention to what's in bold to know that all of these things are going to impact the efficacy of your meds, okay? Not necessarily every single thing that's under it. It's just describing it in more detail. I just need you to know that these things could change the efficacy of your meds, okay? So just like these titles, okay? The dosage, so sometimes depending on what's going on, you have to pay attention to that, especially if you're using steroids. If it's a large area that you're trying to treat with steroids, especially if it's like a smaller kid, you're increasing the amount of steroid that they're absorbing because they're putting it over a large area. So always think about, hey, how much am I telling this person to put on? How often are they putting it on, okay? Because those do play a role because, again, it's all going to end up going into your body at some point, okay? So that the dosage matters, of course. Your permeability of the skin, so anything that would make your corneum abnormal, that is where you're going to see that varying degree of absorption. Even if you have cut it, right, there's some type of damage to the skin, older, younger, think about the bookmarks. Those are where you'll see that barrier kind of not being the reservoir that we typically see it as being, and it won't hold things the same. So your absorption could vary there. Hydration, the more hydrated someone's skin is, the more likely they are to absorb more medication. So if you have somebody who is very hydrated, their skin looks very moisturized, then they are more likely to absorb more of the medication. Speaking of moisturizers, while we're talking about it, if you have someone who puts on like lotions, things like that, creams, after they get out of the shower or in the morning when they wake up, you need to make sure that they're putting on their medication first before whatever that other cream or ointment is, right? Because if I put on some other type of cream or ointment or lotion before, and then I put on my medicine, I already now have that lotion there first, and now my medicine is trying to get through that also, right? So now my absorption of my medication might be altered. Same thing if they have to put it on their face. Before they put on makeup, before they put on any facial moisturizer, anything like that, first thing that they need to do, wash their face, put on their medication, and then they can put on their sunscreen or whatever after. Okay, so medication is always going to go first. Looking at the age, again, when we talk about absorption in kids, they're not just little humans, right? Their body composition, some of their metabolism, all that stuff is a little bit different. So when you get into peds, you're going to look up at this a lot more, but just understanding that some of the areas, like if we put something on a child in the same area that we put it on in an adult, that child could potentially have, of course, a greater absorption rate or greater absorption of that medication because they're smaller. So now we have to amplify that for them, right? Looking at the frequency, a lot of the meds that we have we'll use twice daily. Some of these you will see are used more than that. It also depends on where they're putting it. If somebody has something and they're putting it on their hands, we wash our hands a lot. So if I'm putting meds on my hands and then I go and I wash my hands later, or I have a habit of washing my hands, I'm going to wash that medication off. So reapplication would be required. And think about that when you're prescribing the meds, because a lot of times at the pharmacy we'll get stuff where the patient doesn't have enough. They'll say like, oh, put it over your entire body, and I'm looking at someone who's like 6'2", and we have a 15-gram tube, which is like this big. Do you want them to do this once? Because like this isn't gonna last, right? So make sure that what you're ordering matches with your patient in the area that you wanna apply it on. Looking at your characteristics, just understand that the smaller that something is, the easier that it's gonna be to permeate the skin. Don't need you to remember all of this under here, just understanding that the size of that molecule does matter. And the composition of if it's easily dissolved in water or oil also matters, and making sure that the formulation of the medication is right, which is not something that you would do, right? You're just gonna order it. Occlusion. Talked about occlusion a little bit. So occlusion is, I have a cut, a sore, I put something on it, some kind of ointment on it because you wanted me to make sure that I was okay, and then I put a Band-Aid on top of it. When I did that, now I increase the rate of absorption potentially of that medication because I'm warming up that area. So when we talk about that, you'll see some people do interesting things. Like when people take preparation H, they put it on their stomach and they wrap themselves with saran wrap, and they're trying to increase that absorption in sweat. It's just sweat and like workout and stuff. But you see different things like that. That occlusion is trying to help them get an end result. In this situation with some of our meds, we don't want to occlude, right? Especially if it's a steroid, certain things like that, occlusion is not good for us. We don't want to increase the absorption of that steroid. Then looking at your delivery or the vehicle that you end up using, remember I already talked to you about this. If you change it, it could alter how everything happens downstream with that drug. So just making sure that you understand that that vehicle or delivery system is very important, and you choosing the correct one is also very important. It depends on where it is. Okay, so these are the charts. So previous two slides, what you're looking at is the bold things to know that all of these things are going to deal with the efficacy of a med. And then when you look at these are the different vehicles that you have. Focus on the things that are in bold because these are the things that are going to help you understand the highlights of how you're looking at an ointment, a gel, a cream. We're going to talk about different vehicles, lotions, things like that. This is going to help you say, okay, this is a typical characteristic of a lotion, a cream, an ointment, what have you. Or I have a issue or derm issue in this area, so I need to pick this vehicle to make sure that I'm getting that drug to the right part of the body, right, for it to be absorbed. So when you look at your ointment, think of something that's like Vaseline. So it's kind of thicker, it's kind of greasy. If somebody puts it on, you will see that they have on an ointment because usually their skin will be shiny in that area. So that is what your ointment looks like. And what it's going to do is it can help protect the skin from outside anything, right? So like most of the time we put an ointment thick, greasy. You don't need a whole lot of ointment. And it stays around for a little bit longer, especially if I'm using it and I'm washing or putting water, right? If I'm washing my hands, things like that. If I'm just using water, it might stay there versus if I use soap, most of the time anything will come off. But it's also going to provide that barrier against water. So very good to protect the skin. And then the other thing that I'll probably highlight here is like this thick area. So if something is thick, then you're good to use an ointment also because it can kind of moisturize and soften that area of the skin for that person, okay? So look, go ahead and do the thickened. Your clinical use, most of the time when we're using this is very good in like cirrhosis. Sometimes you'll see us use it in eczema, it just depends. But like very chronic type of conditions where the person's skin is going to be inflamed or they're having like a lot of dryness, we can see that we can use some of our ointments. So good for non-hairy areas, dry, thick. So that's why I told you to underline up here the thickness. But don't use it in a hairy area. So think about putting a bunch of Vaseline on your hair and what that would look like, right? Just greasy, clumpy mess. It's not going to get past the hair. It's going to sit on the hair and not really get to the skin to get absorbed, which is what we need it to do, right? So if you have ointment on hair, not helping get the drug through the skin, right? So not using it in a hairy area. A lot of the times if you have people who do use a lot of ointments on hairy areas, what you'll see is their follicles will start to swell. It looks like acne, but essentially though you have folliculitis. And then here's just an example. We're going to talk about several examples, so don't worry. And you'll see that it says ointment or cream or lotion or what have you after the name. So that tells you what it is. You just kind of need to know what the properties are of each of these vehicles. Your gels, think of something that's kind of light, and most of the time they are clear. And what you'll see is that they have a drying effect. So when people put on gels, a lot of the time they won't tell you that they're having a soothing effect. Some people will say that it kind of stings and burns a little bit, but nothing that would make them not use the medication. So if I have a drying effect, what kind of thing would I think I would want to use this in? A wet condition or a drying condition? The wet condition, right? So that same basic rule that we talked about. Least occlusive, quick drying. They say that whenever it dries, you can't really see it on the skin. That's not totally true. So you'll see where some people, even though they're going through whatever their derm issue is, they're going through acne, what have you, people still want their appearance to look a certain way sometimes. So if that does happen, all they have to do is put their moisturizer on after they use their gel. Very good for anything that's wet, right? So that's what that exudative inflammation is, because it's oozing. So we would be drying it with our gel. And then you see that we can also use this for acne to help kind of dry up those comedones that patient may be having and help clear them. And then you can see, oh, I can use this on my scalp. I can use this on the hairy areas. Anytime I have a patient using any vehicle like this and they're using it on the scalp or a hairy area, tell them to make sure that they're parting their hair, dividing their hair, and putting it actually on the scalp, and not just taking it and going like this, because now you're just putting it on top of hair. It's not going to just magically diffuse through the hair, right? So they have to actually do a little bit of work, open it up, put it down on their scalp if they are using it in the hair. These are different examples that we have. Testosterone, Clindigel, we'll talk about some of these, and then testosterone later. Creams, this one is a very popular one that is ordered quite a bit. You will order this a lot. So when we talk about creams, they're very good vehicles. Patients like them. They're kind of the in-between go-to type of thing. Whenever people put on creams, again, it should vanish on their skin, but sometimes you can see like a little white hue that's kind of left. Again, when you put on a moisturizer, you don't see any of that that's there. So again, make sure that, I didn't have this one, do the intermediate between drying and your ointments. So it's like your middle ground, intermediate in between both of these two things that we kind of talked about. And it's not as greasy as what we would see with an ointment. So think about ointment as like having that shiny, whereas if you put on a cream on something, it's more of a dull kind of appearance. It looks like you like made it matte, kind of. Your clinical uses, when we look at this, again, good for anything that's weeping, so exudative, and then you also see that we can use it in our intravenous areas, so like thinner areas that are going to be more sensitive, we can use those, and then it's good because it can hang out a little bit longer. Let's say it was my armpit. It can hang out for a little bit longer, but it can also not occlude and cause me to have the folliculitis that I could potentially see if I used an ointment, okay? So the cream is a better option and that intermediate option for me to use there because it's not occlusive. And then this is an example, hydrocortisone cream, you can buy that over the counter. The rest of these, your lotions, aerosols, tinctures, and foam. Lotions and aerosols are probably the more common ones that you'll see now. Tinctures, we don't use them as much as we used to back in the day. Like a lot of pharmacies used to compound tinctures and people would go and get them. And then foams, depending on what's going on, you can use them. They not as often. It costs a lot of money, so we don't use them so much. So looking at your lotion, think about a daily lotion that you could use. It's the same type of consistency, but it will have a medication in that lotion. They're going to apply it the same way, not as occlusive. It's very light, okay? So again, just picture your regular lotion. When you look at your clinical use, thinking about this, right, if something is wet, I can use it on that. And then if I'm also thinking about a hairy area, that's great, because I can take normal lotion and put it on a hairy area, okay? So in your mind, just regular lotion, same type of properties that you can use. Looking at your aerosols. So with this, when a patient uses it, you need to shake it. I kind of think of this as like deodorant, right? If you have a spray deodorant, most of the time before you spray your deodorant, you shake it and then you're going to spray it on. This is the same thing whenever you're looking at your aerosols. So that medication is going to be in that gas. So when you shake it, it'll disperse it, and then they can spray it on whatever that area is that they're going to be using it on. This is good if something could spread easily. You don't have to have contact, right? But you also have to be careful that you're not super far away while you're spraying it and then it's getting all over the place and not to the site of the infection that that patient may have or the site of their issue, okay? So good for the scalp and hairy areas. This one is your Lotrimin. So this one is an antifungal that they have an example of, right? I don't want to have to touch my feet that has a fungal infection. I can just spray them down with my aerosol. Your tinctures, these are more drying because they're heavily based in the alcohol with this composition. So good for, again, scalp and hairy areas, and think about these on something that is wet, any type of exudative type of issue that a patient may be having. These are different items that you can see listed here as examples. And then your foam, when you look at your foam, again, same thing, your medication is trapped in this gas. Again, most of the time, it's just a habit for me with the foams. I do the same thing, I shake it. When it goes through the asparagus, that's kind of what's making it foam up. Because if you ever open up a foam, you can kind of see that it's all liquid in there. But when it goes through after you press down the delivery system, that's whenever it changes. So when you think of a foam, think of it as like hair mousse, right, that you have in the container. You usually would shake it before you press it. Same exact thing, higher costs when we're looking at our medication, so just be aware of that. Good for the scalp and hairy areas. Rogaine is a great mental picture for you to use. Paste, powders, and wet preparations. A lot of times when you see some of these used outside of the powders, we don't really have a lot of this in the pharmacy that I would say that I dispense as far as a paste. So these are more thick, dry things. They're not as clean whenever you're putting them on. So think about like toothpaste, and if you were to take toothpaste and just smear it across your skin and leave it, right? Like it's thick and it's gonna dry hard, you're gonna see it. So thick and dry. When you're looking at this, different places that you can potentially use it or the clinical use for it. So any types of like thick areas that have that chronic inflammation like we talked about on the first slide, not applying it to anything that is wet or those hairy areas. And then again, just think about my toothpaste. And then your powders, whenever you think about powder, kind of think about baby powder or any type of antifungal that you could potentially be putting in your boot, right? You're trying to dry things up. You want it to absorb the water or the moisture that is there so that somebody doesn't have a infection that could be brewing, or the fungus or the bacteria can continue to grow. So this has that absorptive effect that you're trying to see. It also can help just provide or ease some of the friction that people could be having if they're what do you call it when your thighs rub together? Chafing. They use powders there, right, to make sure that they don't chafe. Or you could put on shorts. I don't know. And then again, same areas that we were talking about before. So our intravenous areas, again, we're using it there. And then making sure that you're using that right vehicle where we need it to be. Powders sometimes are great, but if somebody is telling you that like it's clumping up a whole bunch, then they're probably going to need to apply it more often because they may be very moist in whatever that area is that they're putting it. And then it just starts to get crumbly and not comfortable, okay? So pay attention to that also. Examples listed here. And then your wet preparations. This I see used more so on like the inpatient side. I don't really see any of this coming through the pharmacy, but you could potentially be doing this in a clinic. You see that this is essentially saying like you're going to take a wet dressing and essentially try to pull out any type of wetness that could be in the whatever that wound is, and ultimately it would lead to drying out whatever that that condition is that that patient has. So this one is kind of like an odd one, helps with the oozing, and then you see different options that we have here: normal saline, dome boral, acetic acid. We'll talk about some of these. Okay. So your dermatitis. When you look at dermatitis, there's different types of dermatitis, and Most of the time, a patient might present to you, they might have a rash, they might tell you that they're itching. Sometimes you might not see anything on their skin, but they can feel that it's coming, and then later they leave, and then they might have a rash. But in front of you, it might be like a couple of bumps at the time. Big thing that we end up asking is like, hey, did you change your lotion? Did you try a new perfume? Did you change your laundry detergent? Things like that then become the answers or the questions that you have. So essentially what happens is they're going to have either an irritant or an allergic interaction that causes them to have that response of the contact dermatitis. So when you're looking at an absolute primary irritant, that one is like, no, you touch it the first time, you're likely to have a response. Whereas your relative primary irritant, they're not as toxic, they're not as strong, so over repeat exposures, then the body will respond to it, and then they will present with whatever that contact dermatitis looks like. So that's where you can see things that happen with like soaps and stuff like this, things like that. So with people who you know that have very sensitive skin, it's very important for you to make sure that you're asking those questions, and you can ask them directly. People are usually not worried when their entire body is itching. And then your allergic hypersensitivity, essentially due to the fact that that patient came into contact with that substance and they're allergic to it, right? So they have that hypersensitivity reaction, poison ivy, things like that, and then you're going to see that contact dermatitis occur. Okay, it's going to show up on their skin. You can also see where some people are just allergic to certain compounds, bless you, and so they have to avoid those compounds or they'll have that hypersensitivity or allergic reaction to it. So again, just be very mindful. The relative irritant is the one that's kind of hard for people to identify. I will tell you what's going on though. But in real life, this is very difficult to find because it's something that they have been doing. It's not a recent thing, right? So when you're asking your questions, be very deliberate with your questions. So for instance, I went to Vegas one year for my birthday, and we were in an Airbnb, and I was like, I don't have to pack soap because we're going to the Airbnb. Day 1 goes, day 2 goes, I was fine. Day 3, I was out, and I was like, my entire body is itching everywhere, literally from head to toe. And I was out with everybody, and I was like, guys, I'm going to have to catch an Uber to CVS or somewhere because I broke out everywhere. And I couldn't figure out what it was. And so I went back through my brain. I'm like, what did I do differently? Besides, I'm not in the same state. What's wrong? I used their soap. My body did not like their soap. Day 1 and day 2, I was perfectly fine. Day 3, my body was like, absolutely not. Okay? So for somebody who has been doing something for a long time and that contact dermatitis doesn't go away, they may not be able to immediately trace back to you to say, oh, it was the laundry detergent, I changed my fabric softener, I did this, I did that. Okay, so kind of walk back with them if there's nothing immediate to say, has that always been your laundry detergent? Has that always been your soap that you were using, okay? This, you can just FYI this or delete it. Not gonna ask you that, there's just different stages, it looks different as they continue to go. So when you're looking at your treatment, of course, if I can avoid whatever it is, let me get away from it, right? So prevention is the best treatment, kind of like what we were talking about with our allergies. But if I can't avoid it, I didn't know that I was coming in contact with it, we have several different therapies that we can use. So first thing that you need to do, get rid of whatever that irritant is. So if we know that it is the laundry detergent, we know that it's the soap, now you gotta throw it away. You can't keep using it. You're not gonna sensitize your body. It's not going to be comfortable. So just get rid of it, right? Go get your regular basic things that you have. And then when you're looking at your topicals, sometimes, again, the same rules that we were talking about before, right? Avoiding certain things. We don't want to occlude or not allow that, that sore that we might have, the lesion, to actually weep. So don't put or occlude with an ointment because our ointments are very occlusive. So making sure that some of these things, that you're picking the right thing. If somebody's been itching a whole lot and then you go and you get an anesthetic or an antihistamine, that might make it a little bit worse for them and make them more hyper-responsive to what's going on. So you have to be careful sometimes with what you're telling your patient to use. And also, can they apply it? Because if I've been itching really, really bad, I might not be able to even use it. And then calamine, this is what we used to use back in the day all the time with for like chicken pox, things like that. You'd have, and you put on the calamine lotion, they tell you that it was helping you and it wasn't, and you were still scratching your skin off. We still make calamine lotion. It used to be pink. They still have the pink one, but now they have a clear one also that you can use. They're saying that it's kind of like a placebo effect, that it doesn't really do anything. So it's something that a person could try, but you want to use some of our other medications that we're going to talk about on the next slide, if you can. So if your patient is mild, again, I will tell you what your patient has. So I'll say a patient has mild contact dermatitis. What can you use? Well, I can use a wet dressing, I can use an astringent, I can use my oatmeal bath, or I could potentially use a low potency steroid, and you'll learn the potencies of the steroids later. So whenever I'm looking at my wet dressings, this is helping me a lot with the comfortability that I have, right? Because some of these things with contact dermatitis, remember I told you I was itching everywhere, right? So when I'm doing that, I can put on a wet compress and it just cools down the area, it decreases the amount of itching so that my body can just go through whatever that natural response is without me damaging my skin and decreasing, right, tearing up my barrier. Because the more I scratch, the more likely I am to cause sores on my skin. So this helps decrease that itching that they have, the irritation kind of helps them heal through the process. And then if they do have a lot of scabbing, it's going to make it to where the skin is healing, but not necessarily putting all those hard scabs around. And some people, when they scab, they also will get a dark mark. So that kind of helps the appearance of the skin after whatever that exposure is also. Your astringents, think about this as like witch hazel, things like that. They're essentially just kind of drying out what's going on. So dries is the big thing that I want you to remember. When you see blanching occur, this is in some patients where you'll see that because it's pulling everything out and drying everything out, that their skin in that area will appear a little bit whiter, but it does go back. So it's not like it's a forever thing that it's going to stay that way. It's just while that medication is getting absorbed that you'll see the blanching occur. When you see this, again, the way that I think of astringents, I just remember like I'm taking something and I'm just pulling it, right? Let's say it had an anchor and I pulled it. I'm trying to dry it out, but I also see the contraction of the tissue, right? So that's why you can see a lot of those other side effects that are happening. The whitening, I think about that. And then I'm also decreasing the amount of inflammation. I'm tightening things up, okay? Your example that we have, your aluminum acetate, just remember aluminum acetate. And then your oatmeal bath, again, something that helps kind of soothe the skin, helps to dry out if they have like those weeping lesions, hand, foot, mouth syndrome, things like that, where you have like an open lesion. You can also kind of put people in that oatmeal bath. They do have to have an actual bathtub to be able to sit into. So if they don't have, a lot of houses now, they just have showers. So if someone doesn't have a bathtub, they can't use an oatmeal bath, okay? And then your low potency steroids, we'll talk about those. So you have 4 options that you can use to treat a mild contact dermatitis. Moderate dermatitis, different medications that you have used, and then you see that we're stepping up what we're doing in regards to that steroid now. So when you have your counter irritant, essentially that's in the name of what it's trying to do. It's trying to say, hey, I want to help with the pain by kind of desensitizing or depressing of those receptors so that they kind of don't feel it. A lot of times when you give some patients a counter irritant, if they have been itching a lot and they have damaged their barrier, it will burn when they put it on. A lot of these do have smell, so think about like your menthols, things like that, they kind of smell a little bit stronger. You will see that happening. Your topical antihistamines. When we talk about antihistamines, we talked about our oral options that we had. We do have things like Benadryl or diphenhydramine that comes also in a spray, and that person can spray it on their skin, which is sometimes helpful because then they don't have to touch it and keep rubbing it and irritating that area. So when you do this, you do see that you can have some sensitization that does occur as a result of that medication, which in some patients it can kind of be like, oh, okay, this is helping me, but it could make their dermatitis worse if that sensitization does happen. Your moderate to high, this may have the systemic effects. That's if it's a huge area that they're putting it on. If it's not that large of an area, you are not going to see this drowsiness happen. If your patient does tell you that they're drowsy because they see Benadryl, which sometimes does happen, just tell them then to apply it at night or once they get home from work, because the larger the area, the more likely you are to see that. All right, now you see your moderate to high potency topical. So when we said it was mild, we were able to use our low potency. In this situation, now we're using our high to moderate potency steroid. And depending on how bad it is, you could potentially, with your severe, end up with systemic. So that, like, in your mind, this should make sense. Mild, I have a low potency steroid. In my moderate, I have moderate to high. I have a moderate. I have a moderate to high potency steroid, and then in my severe, I'm jumping all the way to systemic treatment. So I'm going to give them an oral. Okay. When we look at this, we'll talk about it. But when you use steroids, we want to use them sparingly if we can. But it helps decrease the inflammation. Of course, we know, and it also helps patients stop itching if they are having that side effect occur for them. And then, or symptoms, occur. And then looking at your severe, again, we've been seeing prednisone a lot, right? So this is another, more of an extended period that they're using this, not a burst like when we were talking about our allergies, okay? So this is kind of a taper that they have to help them calm down that response that they're having because nothing else prior to worked. So if you see severe, you're gonna be systemic. If you see resistant, it's going to be your systemic treatment. Bless you. Seborrheic dermatitis. When you're looking at this, just think of different things, dandruff. It can come up when your patients who have different, like eczema, their skin is extremely dry. And so they'll have a lot of patches. I will tell you what's going on, so just look for the condition. When you're looking at your treatment that you have, you can use this ketoconazole shampoo. When we talk about the ketoconazole shampoo, this has an abnormal application, right? So most of the time, you'll put shampoo in your hair and then you rub, scrub, and then you rinse it out. This one, they would have to put it on and they have to leave it on for 5 minutes and not rinse it off. You can also use this on people's skin, okay? So the same thing is happening if they're taking a shower and they're doing it as if they were taking a regular shower. When we put soap in areas, most of the time if the water gets on it, it's fine, it's gonna rinse it off. But they're gonna have to kind of stand back in the shower to make sure that that shampoo is staying on their body for a longer period of time. So don't let the shampoo confuse you that it's only for the head. We can also use this on the body if somebody is having seborrheic dermatitis also on their body, okay? So the shampoo, yes, for your hair, but also they can use it for the body. And then you see your low potency steroid. Atopic dermatitis, which we look at more so as our eczema. Again, I will tell you what the person is having, so don't worry about all of this on this side. What you're going to try to do, if I know it causes that person to have a flare, I need to remove them from whatever that irritant is going to be. And then looking at your hydration, so this is where we were saying with those ointments and things like that, their skin is dry, extremely dry. Okay, and this was one of the things that I told you would be in the triad of somebody having like allergies that you'll also see sometimes eczema. And so the big thing that we want to do is make sure that they're avoiding things that will dry their skin out, because the more things that they come in contact to dry their skin out, the worse their condition is going to be, the more they're going to have a flare. So for you, when you're treating, you can give them things that are thicker and that will stay on their skin longer. Their skin is also thicker because they've been scratching and scratching, and then when that skin grows back, every time it's growing back a little bit thicker, okay? You'll also see a lot of people where they have eczema in their hands and they've like torn up the inside of the palms of their hands because they are scratching so much. Sometimes they don't even realize that they're doing it. So increasing hydration, big thing. We do have also this soap-free Cetaphil for them to wash their bodies with. You can provide that and prescribe that as well. We do carry it in the pharmacy for free. They can buy it over the counter. It's just going to add up, right, if they're using that all the time to take a bath. It's not very drying for them, so that's why it's helpful. And then we also have Vanny cream or like Eucerin, depending on what base you're at. You go out and you buy a little thing of Eucerin, it's like $15 sometimes. It's expensive. You can write a prescription for that. We have it in the pharmacy. If we don't have the Eucerin, it'll be Vanny cream, which is very similar. Again, you're just helping moisturize them. If they have a medication that they need to use first, medication first before the moisturizing that they would be using, okay? Because that's just gonna include everything else that you're trying to put on if you put on an ointment first, okay? Those weeping lesions, again, we talked about what you could use here. So you see your aluminum subacetate, and then your colloidal ointment, corticosteroids. In this situation, this is a chronic condition that this patient is going to have. They're going to need a lot of help from the medication, so medium to high potency. Then we have our TIMs that we're going to talk about, your topical immunomodulators. These are further down the line. You see that they end in crolimus, okay? That's your ending for those. We have two different formulations that it comes in, cream and an ointment. Depends on the patient, depends on where they're putting it as to which one you'll order. And then your systemic therapy that you can potentially have because they're going to be very itchy will be to use an antihistamine. Would you like to use a first generation or a second generation? This is better. We can't use this if it's at bedtime, okay? With our second gen, if I'm out doing my day-to-day, everything, I gotta wake up and go to work. The other thing that I wanted to tell you too, if you're using an antihistamine like Benadryl at night and they're not gonna get at least 8 hours of sleep, make them use something else. Go to a second gen because that Benadryl gives you like that hangover effect. So that you don't sleep enough, when they wake up in the morning, they're still gonna feel drowsy and crappy, okay? So they have to have enough sleep that night before if they're gonna use any one of your first gens that cause this sedation. All right, your topical immunomodulators, or your TIMs is how we kind of refer to them. Your mechanism of action is essentially trying to decrease or inhibit that T cell activation. When we talk about calcineurin, what it does is it binds to the T cells and it causes them to have that immune response. So their system becomes activated. You'll see the inflammation. You'll start to see the itching, that whole cascade that comes along with everything. So what this medication is doing is it's binding to the T cell, binding to block that T cell activation so that we don't have that whole cascade and that inflammatory response, okay? It prevents everything else downstream from happening. So now nothing else can happen. Your patient is going to be a little bit happier. So that FKB12 protein is what it's binding to say, hey, I don't want you to have any activation or any contact with this T cell to cause the inflammation. So medication binds to your FKB12 to inhibit your T cell activation, which then decreases the inflammatory response. Okay, so it's kind of going this way, backward. Your products that you have, your pomalidomide and your tacrolimus, you could prescribe these easily. I see it a lot in the pharmacy. Your clinical use, so your atopic dermatitis, or if you have somebody who has a skin condition that is very chronic, where they have a lot of the inflammation, and they're starting to have like that plaque psoriasis, which we'll kind of get into a little bit, where they have like those scaly patches. This is one of our first line things that we have that is a steroid sparing medication, okay? Remember, our steroids come with so many different side effects. So if I can decrease the amount of steroid that I need or put it off in using it, I can then have a medication on board that helps me do that. So that's why we like to see the steroid sparing. So a first line steroid sparing agent that I can use in all of these areas that I talked about. And I can also use it in my thinner areas, so like my genital area, my face, all of those different things, my armpits. It's safe for me to use in that area versus when I'm talking about my steroids, I then have to worry about the potency and if it's safe for me to use them in those areas, okay? So this is not the same thing as a steroid. When you're looking at your efficacy, you have your tacrolimus and then you have your pomalidomide. Your tacrolimus is equivalent to what we're going to talk about with our steroids as a medium potency, whereas your pomalidomide is less potent, okay? And that one is looking at your low potency or comparable to a low potency steroid. So again, just looking at the complexity of you have these two drugs in one class, pay attention to the mechanism, of course, how it works, and then looking at when do I use this. This is a great thing if somebody can't tolerate steroids. This is a great thing if I want to avoid a steroid. And then looking at the areas that I can use it in is also very important. So we'll also be able to distinguish between the two and kind of say, oh, my tacrolimus, this one is a little bit stronger. Think about somebody tackling somebody, right? This is equivalent to a medium potency steroid. Whereas my pamcrilimus is kind of like, it's just off there to the side. It's not as potent, less potent, more of our low potency steroid. Again, your big thing that you're going to see, and a lot of these people will feel this skin burning, right? Because they've been itching, they scratched themselves, they messed up their barrier. In this situation, you see that 50% of your patients can potentially experience this, so that's a big deal. The skin burning, the warm skin infections, right? Especially if that barrier has been broken, and because it's an immunomodulator, that's why you can see those infection risks increase. And then flu-like symptoms, again, because it's an immunomodulator, you can see those flu-like symptoms occur. When you're looking at your UV exposure or somebody going outside without sunscreen, because again of the immunomodulation that occurs, and it can increase the cancer risk that a patient may have. Okay, so make sure that they're wearing sunscreen or that they have on protective clothing if they're going to be using these. And then you see the black box warning, which is the big deal as to why we also don't want to couple that with them going outside, is the increased risk of them having skin cancer and potentially lymphoma. Not very common, so something for you to watch out for if you do see new moles or anything like that, or they're growing on a patient, bless you, make sure that you're paying attention to that. Okay, so rare, but it was serious enough for this to now have a black box warning. And then, just like with our steroids, we'll talk about how we want to limit the use of the steroids depending on the potency. Same thing's happening here because of that black box warning. I want to decrease my patient being on it for a long period of time, right? So you don't want to go over that 6-week mark. You can use it intermittently if you need to, but sparingly is how we would say. So never have them on it for a period of time that's longer than 6 weeks. You will see some patients where they're put on it, and then they'll be taken off for a little while. They'll have another flare, and then you can put them back on it. That's okay because it's not like a continuous administration of it. So if you ever start to hit that 6-week mark, then you would have to say, okay, let me switch to a steroid now because that person has ran out of time on their 10, okay? So you have to make sure that you're watching that. Let's do our 10 minutes and come back.
You only got 8 hours of sleep. When it was just really hard to get their thing get them ready for it. At Jack's age, she's probably sleeping through the night. Sleep deprivation is what causes greatest Why are you so tired? The first time we talked through it together. The second time, did one iteration and talk through it together. The second time, switch, do one iteration, and then from then, like the next time we meet, it'll be we have time for 2 iterations. There's only 4 of us.
She never told me more about it. What can you do today? It's all in the tips. It's all in the tips.
You notice we start GL2.
Come on, let's be so fast, so you know I'm not
So there's 10 lectures published. Right now, between the 7 that are published, that's like 3 more slides. So there's 3 more slide decks that we don't know. And we only have 7.
I was just wondering when she said that. I was just waiting.
There's pictures of just like the last lecture on Tuesday or Wednesday, we test that Friday.
Depending how much time we have between this and the for lunch. Oh, there's no. Absolutely not. Oh, the month now.
Yeah, like.
It's the last day of March. So it's like I think we have 3 more lectures this week, and then here's how it is. So next week we don't have our elements. So first on one, and then she teaches in Thursday. Yeah, unless you have some more to do, the rest of the week it's just like 3 or 5 days. Yeah.
Then we end the day with the whole man.
I can't do. Nerd.
Yeah, we're already like at this point in sophomore semester we were like having a week off.
Was it? Yes.
You're saying like the actual one
I know what's wrong
I think it's the lab is open.
yeah. I honestly don't. I don't. I mean, it's a mock. And there's a mock one in the middle.
Yeah, but those are not free.
Yeah. I remember that graded. I don't know.
I think they could like tell you.
I don't know if you're.
What's graded is
They might tell you to
Yeah. I just don't know. I just don't think you can
they could find
like if you go to the hospital, it's like I have no idea what I'm doing.
it's like a remedial.
That's not
no, I'm not saying it's for free. Now what I'm saying is I don't have to
No, yeah, I don't think that's okay, but I think you still have to do that.
So we got the basic, yeah.
March, and at the end of April, you're halfway through. I'm looking at block one. It's like 10 slide decks, and then he has 3 reads, which is like AMP2 for me there. And I was just like, why did I go? And they're like 50 slides. 50, 5-0. Yeah, it's like 10 of them. Yeah, so I was like, it's a lot. Well, this test is next week, so I don't think it's that. It's not. If they want, yeah, next Friday. That's his test. Yeah, like actually goes fast. Yeah. Yeah, it's because of next week. It goes endo, ID, GI, then neuro, then ortho, and then Pharm again.
Diarrhea.
Diarrhea. It's a diarrhea competition. No, never.
I think that's my best for that.
Imagine being like, or like you tell your parents. Yeah. Holy.
That's mental. I've had a couple friends.
And I was 7 years apart. Because we didn't. Anybody was just
Whatever it is.
put all their crazy infrastructure next to school.
Oh, sorry.
I've seen surveys questioning the intentionality of their lack thereof. The fact that close to
Yeah.
I never did that. All right, let's keep moving. The next one that we're going to talk about is going to be our acne. Acne is something that you can see very commonly. A lot of people like to treat their acne because they don't want to have the comedones on their face. And so this is something that you'll have a lot of your patients coming in for, that you can potentially treat several different things and different conditions that you will see that kind of fall into this category of causing different things on some people's face. So impetigo, when you see impetigo, essentially what's happening is your staph and your strep has set on that patient's skin. Gram positive, gram negative. Y'all didn't want to tell on y'all. I'm gonna tell Major Hurlsberg that y'all forgot. Tell me that you forgot. No, but gram positive, right? Cockeyed, very big things that could potentially happen to your patient. Most of the time, whenever you're looking at this, just make sure that you understand what you're looking at. For my exam, right, I'm going to tell you what they have, so it's not like you're diagnosing anything. What you're going to do is give them mupirocin or Bactroban. Because this is a bacterial infection that they have that has kind of presented this way, right, is giving them these sores essentially on their face. What you'll do is you will have them start on the outside of wherever this sore is. So like I would say, okay, you're gonna go around the outside and then work your way in. Go around the outside and work your way in. The reason why I always tell people outside to in and not inside to out is so that they don't spread it, right? So if I start on the outside and work my way in, I'm only gonna get smaller versus whenever I go the opposite way, most of the time people will go bigger and then things kind of start to spread. Make sure that they're washing their hands before and after they apply their ointment, okay? Because we already have an infection, we don't want to spread it all over the place. So antibiotic mupirocin that we're going to use 5 days, and essentially what that's trying to do is stop that bacteria from being able to create its protein and survive, okay? So we're trying to kill things that are going along with this patient. This, just telling you what acne vulgaris is, understand that for some people, especially if they have darker pigmentation, they are likely to have dark spots that may be left behind after they have whatever that breakout is, okay? But this can happen in anyone, and then you have people that will then try to chase fixing the dark spots that they have, right? So with this, your big thing is making sure that patients don't pop them, that they try not to scratch them, and that you're giving them something that's going to be beneficial to essentially dry up whatever that comedone is that they have, or get rid of the actual cause of the underlying cause of the acne. So this is essentially, you can cross this out, FYI, telling you what it is. Now, how does this happen to a patient? Let's say I had my follicle plug, that could happen, right? I'm putting ointment on my face, all over my face to moisturize it, and now I have clogged my follicles. Or if I'm a person who has very oily skin and my skin makes a lot of oil, makes a lot of sebum, I can also have the follicles getting clogged that way. So when I look at this, I have a different mechanism in which it can happen, which is also if I have bacteria that colonize. Remember, we have our normal skin colonization of bacteria. If I have an overgrowth, then you can also see where someone would present with acne as well. Your thing that is your biggest culprit that we have is going to be your P. acnes that occurs, and remember that is an anaerobe. This is going to be important because some of the medications that we use they may not work because of the bacteria being anaerobic, so we have to make sure that we're using something that targets that anaerobic drug. Because remember, we talked about inherent resistance. So if I don't need oxygen, you using something that has that type of mechanism isn't going to work for me. Don't worry about the contributing factors. I want you to kind of know what's going on here, and remember your P. acnes because we have medications that we're going to use to target that. Slow progression being seen when we talk about treating talk about treating acne vulgaris. People want immediate results, right? I want to see that I'm using this medication and it makes me better. A lot of the times when I'm using these medications, what you might see is a flare and it gets worse before it gets better. So before you start busying yourself and kind of fixing your patient, have them on that medication for at least 1 to 2 months before you try to change anything, okay? You have to give it time to work. Remember how we talked about like our antidepressants, right? Takes a little while for it to kick in. So this is the same thing with the acne. Takes a little while for it to kick in and clear things up. If they have normalizing follicular keratinization, then I have my benzoyl peroxide, my retinoids, and azelaic acid. We're going to talk about these. If my skin is just very oily, right, so decreasing sebum production is my goal, then I have my retinoids, and then I can also look at someone's hormones, which we can also alter with some birth controls in our females. There could be like some type of hormone imbalance even in males that could happen. We don't use our birth control in our males, but there could be hormone imbalances and things that are happening, or someone is taking something like testosterone that could be making their skin increase that sebum production. Suppressing bacteria, so remember it's our P. acnes that we were talking about, so I can use antibiotics, I can use my benzoyl peroxide because my benzoyl peroxide targets those anaerobes, retinoids, and azelaic acid. So I have lots of different options there, and then if it's just an inflammatory response that I'm looking at, I have my retinoids and my antibiotics that I can also look at. So again, looking at your type that you could potentially have, what are you trying to do? What is the underlying cause? Bless you. And then you're gonna pick a medication based off of whatever that underlying cause is to actually treat the condition, okay? So I will say, they have blah, 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 and you will say, cool, I wanna use this med, this med, this med, or this med, okay? Now, getting into the mechanisms of all these drugs that we just saw. So you have your benzoyl peroxide. Very good option, very effective option that we have. This is our most effective topical agent that we have for our acne vulgaris. Your mechanism of action is releasing oxygen, which will then kill that P. acnes, because your P. acnes is an anaerobic bacteria. It doesn't want oxygen anywhere near it, right? So because it's an anaerobe, that oxygen that's being put off by your benzoyl peroxide is making it an unlivable, unsurvivable habitat now for your P. acnes, okay? So, big thing with this medication. It is fantastic. But people will complain, the number one complaint is the dryness and the irritation that they are going to feel from using it, okay? So, it is supposed to be that way. It is an irritant. That is a part of the mechanism by which it works. And then it starts to kind of turn over those cells. So if somebody does have dark spots also, you'll see where sometimes this helps like kind of lighten them a little bit over time, because the epithelial cells are just sloughing off. You have higher skin turnover, okay? So the appearance starts to look a little bit better as well. So these are just by way, that's clearly what you want to have happen. Clinical use. So for my patients who essentially have acne, it doesn't matter if it's inflammatory or non-inflammatory. Told you it was the most effective thing that we have that's topical. People can also get this over the counter as well. So make sure that you're aware of that, but we do have this in the pharmacy for us to prescribe. You see how big of a difference this can make in some of our patients. Up to 75% of a response can be seen in those in the acne from just using a topical application. We don't have to do something that's as systemic as some of our other options that we have, because they do come with a lot of side effects. If you combine this with another medication, just like we were talking about with allergies, just like what we talked about with our POM meds, you can see an increased response, because now you would be hitting two different targets as to trying to control the acne that patient has. So you will sometimes see this added with erythromycin, and they enhance the effects of each other whenever we have them working together, and so we'll look at that. Adverse effects. A lot of burning and irritation is what people are going to complain of the most. If they have very sensitive skin, they don't manipulate, they don't do things to their face often, you will see where they are going to be very, very sensitive to this. If they can get through that cessation that happens for the first week or so, most of the time they'll be okay. Afterwards, it does go away, okay? So you just kind of have to bear through it. Sunscreen, because of the photosensitivity, remember I have increased that turnover of my epithelial cells. So they should be having some type of sunscreen or skin protectant on. Also the same thing with their clothing, going outside, like make sure that they can put on a hat if they are using it in other areas, because some people have acne on like their back and their chest, so you can use this in other areas besides the face. So when we talk about acne, don't just think about the face, that's where we see it the most, but some people also have it on their chest, their back, they can have it all over their body, to be honest. Looking at your application, again, if somebody doesn't typically do things, right? They're not like, oh, they walk in, they're not saying, hey doc, yeah, I get chemical pills, and I also do micro needling, and I do all these things. I also have UV red light therapy on my face. That person, their face is probably pretty tough. The person who's like, oh, this has never happened to me, and I've never had any acne before, you're gonna need to start with a lower dose, right? Because that irritation and that burning will probably make them wanna not take the medication. So you have to tell them to stick in and hang in there. And understand also that initially this may make them look worse, but after that 2-month period, they should start to see the benefits of using the medication. Discoloration of fabrics. If someone has black sheets, gray sheets, anything that's not a white sheet, it will bleach the fabric because of the peroxide, right? Benzoyl peroxide. If you just pour peroxide on something and you leave it, I know back in the day we used to try to dye our hair with peroxide and leave peroxide on there, right? So like same type of concept. So what we typically will tell people is either to, I tell people get a white pillowcase for whenever you're going to bed and just sleep on that white pillowcase. Because if you have nice linens that are any color outside of that, you will see where they start to get discolored over time. And remember, they're using this for a long period of time, all right? Our topical antibiotics that we have, so the clindamycin and erythromycin. Remember, I was just saying with that benzoyl peroxide, you can see where we can add that to these drugs to make them better. It enhances the response from you just using this antibiotic topically. So Cleocin and then my T-stat. And then I can combine them together. I have my Clinda with my benzoyl peroxide and my erythromycin with my peroxide, combination options. You can start with just the benzoyl peroxide by itself. If you are not getting response after that 2 weeks, then that's when you can go and say, all right, let me add on my topical antibiotic to that, okay? Suppresses that P. acnes again, right? Same mechanism that we had. This is more for my severe patients that I would say, hey, they're not responding to just that benzoyl peroxide, let me try this. Or if they came in, they presented and they were severe when they initially came in, I might just start the antibiotic, or I could start the antibiotic with the benzoyl peroxide in it. Depends on how that person's face, how sensitive they are. So I like to start with one thing before I just immediately throw on two, okay? So just make sure that you're understanding your patient needs to be able to tolerate whatever you're gonna throw at them. Most effective when I combine it with my benzoyl peroxide. I also have retinoids so I can layer this because I would put on either my topical antibiotic and then follow it by a retinoid to kind of have two different medications on my face at one time is essentially what's happening. And then when you look at the function of the benzoyl peroxide, essentially remember we're talking about antibiotics. So with antibiotics, we always worry about resistance. The level in which we're using to treat topically the acne that the patient has on their face is not the same as how we would treat a bacterial infection, okay? So that rate of resistance, can it happen? Yes, but it's a lot slower than if I were systemically like taking an antibiotic. And even when I systemically take an antibiotic for acne, it's also still a lower dose than what we would typically see whenever we're treating an infection, okay? So that rate of it, the potential of resistance is still there. When we give it with the benzoyl peroxide, this kind of helps decrease that resistance that we potentially see. Adverse effects, especially if it still has that benzoyl peroxide in it, you're going to see some of that burning that can happen. And then you see C. diff, right? Pseudomembranous colitis. If they continue to use this medication, which they're going to be on it for a little while, you could potentially see an increased risk of C. diff with your Clinda, right? Clinda was our biggest offender that we talked about with C. diff. So if I have that, I'm likely to see that occur, okay? Systemic antibiotics, what we were just talking about, your minocycline, doxycycline that you have. Again, this is your more, they didn't respond to their topical, now you're gonna go to your oral options that you have. If there are existing lesions that are there, and this is what's important to kind of tell your patients, if they have existing lesions that are already on their face, it's not gonna make those go away, those are gonna have to run its course. What it's doing is trying to say, hey, I won't allow any new ones through, okay? So that's the job of your systemic antibiotics. This is after you have tried your topical. This makes sense, right? I don't want to expose my playbook if I don't have to systemically. So I'm going to start with that topical because I have less systemic absorption happening that way than if I give them an oral. And these are my orals, okay? Prescribed daily for over 4 to 6 months, a long time for them to take it, but remember that dose is not the same exact dose that we have whenever we were looking at our infections, okay? So, does anybody remember what drug class this falls in? Tetracyclines, right? So remember those little things, because they're going to keep coming up. Your pants, you have a pants, keep those things in your brain. Retinoids, all right, y'all are like, we got to deal with this first. Get the pants. Okay, your retinoids. When you're looking at retinoids, these are very popular. They used to be very, very popular back in the day. What they essentially are vitamin A analogs, and they're decreasing the sebum production that a patient may have. So like when you have somebody that's presenting with oily skin, it helps a lot with that. So if I decrease the sebum production, I'm also, by way, starving my P. acnes, right? Because it doesn't have anything to feed off of. So I can introduce oxygen, or I can take away its source, which is that oil. So if I'm drying stuff up, now it has nothing to kind of hang out in. You also can see some decrease in inflammation that can happen because you're not going to have this chemotaxis, so not everything isn't going to be coming to that area anymore, causing the inflammation that they will be experiencing. Clinical use, you tried that benzoyl peroxide, right? Remember that was our most effective thing that we had. I also said, okay, let me try my antibiotic, because that was the next thing that we said we would do, potentially a combo of both. But this is where you're saying, hey, I'm not getting the response, so then I could potentially use a retinoid, or I could use either of those two that we just talked about and stack on the retinoid as well. First line can be first line if somebody has that inflammatory or non-inflammatory, because remember here with our mechanism, it's reducing the inflammation by decreasing the amount of mediators coming into that area. So I'm having a good option instead of, again, using a steroid to decrease inflammation in that patient. Adverse effects, this is very, very drying. You will see people's skin initially whenever they're using it. It'll be very flaky, and it'll kind of peel off and flake off. That does get better over time as they continue to use the medication. If you have somebody that has a darker skin complexion, or if they have a lot of dark spots from the acne before they came in to request the medication, you can see these initially kind of get a little bit darker, the dark spots, before they get better. So you do see that darkening. Sunscreen, again, most of these things that we're going to talk about, they're going to cause photosensitivity. And then you see that when you're looking at your patient, please let them know this, because people are coming to you because they're already worried about their skin. And then when we give them a medication, if they experience a side effect or they feel like their face is going to burn off, is what some people are like, oh, this stuff really burns. We're talking about the benzoyl peroxide. You have to tell them those things and let them know that it will get better so that they stick with it. Because if they start it and they stop it and then they're trying to start it again, those symptoms come right back. Those initial symptoms are going to come right back. So when you're looking at this with that flare that might happen after they start this medication, usually they're not going to see anything happening. They're going to just be feeling like they're seeing that dryness and everything that's happening on their face. But after, like once it hits about week 2, they may see where their face is breaking out more. This is getting all of that old stuff out, right? We said our oral antibiotics didn't really do that. This is going to make them kind of flare up a little bit, and then all of those old pimples and all that good stuff is going to start coming up and showing up in their face. So it looks worse before it gets better, okay? Pregnancy. If someone becomes pregnant and they're using any of these, even though it's topical, they should not be using these in pregnancy, okay? So you see that you have tretinoin and adapalene category C, which is not our fantastic category, which is why I said just don't use it. But your tazarotene and your isotretinoin are category X, okay? You're not going to use them at all, absolutely contraindicated in pregnancy. So C versus X, C is not great, but it's just saying we don't have any information to support doing it, which is, that's for me is a no. Your category X, we know that it is potentially teratogenic. We know that it can cause issues in our patients. So your tazarotene and your isotretinoin, category X. When you see this as far as like the UV degradation that occurs, again, sunscreen is very important, but what we do is we tell patients to use it at night. They're not going to be outside, right? After they've taken their shower, they're in for the day, they're going to use their medications, and they take it overnight so that we don't have to worry about it. But in the morning, they still need a sunscreen to prepare themselves, and they can wash their face in the morning, okay? Looking at our options that we have, tretinoin, adapalene, tazarotene, all different options. You see that they come in different vehicles, so just depending on where they're putting it, what the patient is worried about as far as appearance and how it dries on their face. So someone who has darker skin, so like sometimes whenever I put on gels, it makes my skin turn whiter. So sometimes I may want a cream And if that makes my skin turn white, then I'll go to like a liquid or something if they have something like that available. But again, moisturizer fixes all of that. So just put on the medicine first and then put on a moisturizer and then their sunscreen. Your tretinoin, you see that this can be added, like we said with our retinoids, it can be added to all the other drugs that we had talked about before. So our topical antibiotics or our benzoyl peroxide. Adapalene, this is now available also over the counter, the different gel. Different strengths are available in this as well. So remember with your patients, start low, go slow to try to make sure that their skin can adapt to the medication that you're putting them on. This one doesn't have as many as many side effects. It's better tolerated than some of our other options that we have available. So tretinoin, we're going to talk about tretinoin in the sense that it was very, very popular. It is still very popular. If you use it, just make sure they know about the skin, like the dryness. That is the biggest thing that people complain about here. Not as common here, but it still happens. Your tazarotene, again, best efficacy. This one is only available through a prescription. We can use it also for our psoriasis. And then looking at this, the gel formulation, not the cream. Cream is usually more soothing, whereas our gels are usually more drying. So you see that this one is almost as irritating, causing that sloughing, the skin dryness, as our tretinoin. Okay, so adapalene gets an A+. It's a little bit better. And then your tazarotene and your tretinoin, those are the ones that are more irritating, that cause more of the drying. So your ones that start with T. They're not terrible, but they're tough. Your isotretinoin or Accutane. So this one, I have seen a PCM maybe prescribe this once or twice. Most of the time, they don't want to touch it, and they will send the patient to derm to see if they really need it. But you guys have the keys, I believe, to prescribe it. When you're looking at this, moderate to severe acne is when you're going to be prescribing this. They will tell you to measure the size of the comedones, make sure that it's absolutely necessary for you to give this to a patient, especially if they're in that childbearing age, which is usually when people are experiencing acne. The adverse effects are very, very pronounced whenever you're using this medication. So this one is our first. This one is our oral, well, our second ones that we've seen. But this is our oral medication. And then what you'll see is a lot of dryness. So I just think about everything being dry. Skin is dry, lips are dry to where people's lips will crack and bleed. Sometimes they're so dry that they will even change colors, very, very pink and just skin coming off of them. So I always tell people to, or I will also ask the provider to order Vaseline for them to put on their lips because it's very, very bad. The dermatitis that could happen, agranulocytosis, not as common, but could potentially happen. Elevated liver enzymes is something that can also happen, which is why we monitor their LFTs while they're on this medication. Watch out for people who have depression or any type of psychosis, any mental issues. You're going to continue to monitor those patients closely. If you prescribe this, they have to come into you every single month anyway because you can only prescribe a 30-day supply at a time. Okay? So every month they're going to be coming in, bless you, because you have to check their LFTs. You also have to make sure that if they're a woman that they're not pregnant. Okay? Because that is one of the big things with this med, it is teratogenic. We just said that it could cause a lot of birth defects. Photosensitivity, we already talked about that, right? We're going to use that sunscreen in a lot of our patients who are doing this. So, contraindicated in pregnancy because of the teratogenicity. So much so that they have a REMS program called iPledge. So with iPledge, the pharmacy has to enroll, the patient has to enroll, the provider has to enroll to say, hey, we are all aware of the risk, the patient has been counseled on the risk, and we know that they have to take this medication a certain way, and they're also signing saying that they're going to be on 2 forms of birth control. If they decide to say that they're abstinent, what abstinence means while they're taking this medication, they have 0 sexual contact. Okay? None. They can't go out one night, get drunk, and no. 0. So we like to always say you need 2 forms of contraception. Okay? I want to make sure that we're good. all right? So when you look at your iPledge RIMS program that they're having to register for because of the traumatic pregnancy, they have to have 2 negative pregnancy tests prior to you prescribing the medication. There is a controversy because some providers were letting the patients do the pregnancy test at home. And they were like, I'm not pregnant. Who's verifying that, right? So most of the time, you okay? You okay? You will be. Okay. So now as of November, I think of 23 or something like that, now they have to have the blood test done in a facility under supervision, whether it's blood or pee for a pregnancy test, it must be done under your supervision if you're gonna prescribe it, okay? So no at-home pregnancy test. 2 of them need to be done prior to, and then they need to have one every month while they're taking it to make sure that they're not pregnant. As far as your people who need to use contraceptives, so when they studied in men, they haven't found that a male taking Accutane would cause any issues. But if it's a person who can get pregnant, so the woman, she has to have those 2 forms of contraceptive. So when we talk about contraceptives, this will make a little bit more sense, but you want something, there's one primary and one secondary form. Your secondary form is the one that you're relying on to actually physically put on a condom, a cervical cap, a diaphragm cap, like they actually have to use a protection method that they would use to prevent like an STD or STI. Your primary form could be, I have an IUD, I take a pill, I have a NuvaRing, I have a patch, I have a vasectomy, I have my tubes tied. They still have to have 2 forms even if they have one of those things, okay? So 2 forms because we don't want anybody sneaking past the goalie and they get pregnant while they take this medication, right? Because now we cause issues with the baby, all right? So very serious thing, remember your iPledge, and then your monitoring, we talked about our LFTs, our lipids, that pregnancy, you're always gonna be making sure CBC because of that agranulocytosis that could potentially happen. Don't listen to somebody just saying they're abstinent because that abstinence means 24 hours a day, 7 days a week for the entire time that they're taking this med, they're not having sex. If they're gonna stick to that, then fine. All right, rosacea. When you look at rosacea, we don't know really what's happening. We do know that it doesn't appear the same way as our acne because there's no comedones, there's no lesions that are pregnant. The person is just rosy, right? Rosacea. They have like a red appearance to their face. Most of the time, even though we don't know the mechanism, it seems to be that they're having triggers to sometimes exposures or irritants. So like when people drink alcohol, sometimes they may become redder, things like that. Sometimes this could be that rosacea. And then you also see the Bacillus oleranius. That could also be a potential cause. Anything else that we talk about, like menthol, eucalyptus, spearmint, things like that, those things can also increase redness in a normal person, a person with rosacea, that's an irritant to them, okay? So I will tell you that they have rosacea, don't need you to tell me how it happens or what they look like. Whenever I'm looking at my therapy, I have different options that I can use to try to help them with the appearance of their skin. When you're looking at this, you have most of your patients, again, are not going to have the comedones. If the comedones are happening, you need to see what the underlying issue is because it may not be the rosacea. So there are several different things that we can do to kind of help them. You have your metronidazole, your azelaic acid, your sulfacetamide with the sulfur, and then your bromonidine. When you look at these, some of these come on and off of the formulary. So if you're going to prescribe something for rosacea, use the TRICARE formulary lookup tool that we always tell you about. Because this is a thing that is up and down as far as what's going to be approved, what's not. They change this frequently. So again, your metronidazole is just helping if they do have pastules that are on their face. Your azelaic acid, again, if it's mild to moderate, very good option. Doesn't really irritate people too much. But they could potentially have burning and stinging that happens, but it's not as often. Your sodium sulfacetamide and your sulfur. With this one, it smells kind of funny, so people don't really love to use it, and they're putting it on their face, which has their nose on it, right? So some people don't want to smell that all day. And then your bromonidine or your Muvaso, this is for your patients who consistently, their face just always looks red and flushed, okay? Red and flushed, red. Okay, so just make sure that you're looking at that. Again, TRICARE formulary lookup tool. All right, your azelaic acid, very good medication. It is an awesome drug. Again, this is one of the ones that goes off and on. We think that it has antimicrobial properties to it. We think that it helps with the keratinization that could occur, so we can use it in rosacea. We also have the possibility of using it in acne, but what we see is that it's different vehicles and it's different strengths, depending on what you're using it for, right? So for my rosacea, it's not as strong as it is in my acne. In my acne, it's more of a soothing thing, my cream, versus with my vehicle, versus my gel or my foam whenever I'm looking at rosacea. You see that it's kind of comparable when we talked about our topicals that we had with our topical benzoyl peroxide, our topical antibiotic, and then looking at our retinoids, which is the tretinoin. But what we see here is that we don't have all those side effects. We talked about the teratogenicity of a lot of those meds. We talked about how they have a whole lot of stinging, burning, and it's common to see those things in this class. Can it happen? Yes. Is it as common as those other drug classes? No, it's not as irritating, okay? So you see the burning, stinging, tingling that could happen. Hypopigmentation in your darker skin patients. So what could happen is, if somebody has dark spots, they could potentially try to use something like Azalex to help with those dark spots, because what it does as an adverse effect is that it causes hypopigmentation, so it'll make it lighter. But then they can have blotchy skin if they're not just putting it on that area that got darkened, okay? So in anyone who's using it, if they're trying to spot treat something, you will see where they have like varying skin colors, okay? So they kind of make themselves look a little bit worse. This is what we talked about already up here at the top, your topical for your acne, and then your topical for your, oh my gosh, I'm saying this backwards. Your topical for acne versus rosacea, you have different strengths of it available, okay? So just be aware that there's different strengths depending on the indication that you're using it for. Ravaso, or your brominidine gel. This one, last I checked, did require a PA. So a prior authorization that had to be filled out. You go online, TRICARE formulary lookup tool. It'll tell you everything that they would have to try before you prescribe this. Okay, so that you don't waste your time, that you don't waste the patient's time. Make sure that you're looking at the PA to see that they do meet the qualifications to get it. Mechanism of action is that alpha-2 agonist that you see there. You also see that you can see some vasoconstriction. So think about how we had our meds for like red eyes, things like that. We were able to decrease the red eyes because we were doing that vasoconstriction. So this is kind of put that in the same bucket in your mind. Again, we said that this is going to be for our persistent patients, and then looking at our adverse effects, you can see that flushing that occurs because I have vasoconstricted in that area that I applied the medication. So that's why they may look flush, but that skin color will return later. So it's not something that's going to be permanent for them. And then if they are putting it on very frequently, not usually as prescribed, or if they have a big face, I don't know another way to say that. Like if their face is larger, right, you're increasing the surface area, so you're more likely to have now an increased dose of the medication. You can see some of those blood pressure lowering effects happen. Psoriasis. Okay, so when we have psoriasis, this is where you can see kind of those plaques. Some people can have it in smaller areas. Some people will have it all over their body. It's an autoimmune disease, no cure for it, but we have medications that can kind of help us manage it for that patient. It is something that we think might be tied to genetics. We think that it may be tied to the environment. We don't know. So I will tell you that they have psoriasis, and then I will tell you what classification they have as well. So mild to moderate versus moderate to severe. When you're looking at this, your treatment is going to vary depending on what I tell you that they have, right? So your mild to moderate patient is a smaller area of their body. So this makes sense that I can use something that's topical, right? It's not a huge area, okay? I can, don't have to, have the UVB. What the UV does is the UV slows down the skin cell production. Remember, they're having these plaques in that skin building up a little bit more. So that UV will slow down that plaque thickening, essentially. And so that's why we can combine the therapies in the two. So in my mild to moderate, I don't have to do that, but in a smaller area, so I can just use a topical. My moderate to severe, and on the exam, I see that this says, right, mild to moderate, moderate to severe. Just put mild up here because I don't want to confuse anybody. Just cross out moderate to severe. So if you have a question, I just want everybody to know, and I don't want you to have to think too hard. So mild up here, put mild. And then here we'll say moderate to severe because it's a larger area, right? So because it's a larger area, now my treatment may have to change a little bit. I can potentially use my topical agents. I have to now use my UVB because it's a larger area. Now I need to kind of double prong attack this. And depending on if that doesn't work or if it's a very large area, I may be on now systemic options, right? Because it's a bigger area. Do I want to try to tell somebody like, oh, get it on your back, put it on your neck, put it on your legs? Like, what is, I can't reach my back, right? All these things. So in those situations, systemic may be more appealing to your patient. Topicals, first line, if it's not widespread, right? The more widespread, now I'm looking for something that's going to be oral because it's systemic. Okay, here are my different options that I have. Depends on, one, how I tell you. So I'm going to say your patient has psoriasis. It is mild or it is moderate to severe. How are you going to treat them? Are you using topical? Are you using the UVB light? Are you using systemic options? You should never be using systemic in your mild patient unless they are super resistant to everything else, which that wouldn't be your problem at that point, okay? So your topical agents that you have, steroids, coal tar. Coal tar is very messy and it smells. Your vitamin D3 analogs, we have different types of calciums that we'll look at your vitamin 3 analog. Calcitrol, calcipotriene, and then a combination with your betamethasone, which is a steroid. So then you're kind of double pronging with this one, bless you. Tazarotene, your TIMS, these we've talked about a little bit. Your UVB phototherapy, remember I was telling you this kind of helping decrease these plaques and the thickness that they have in those plaques. And then you have your different oral agents. Remember, this is after you've tried these topicals. So if these topicals aren't working, that is when you're going to progress to then using oral, or if it's a very large area, then you're going to have to give them that systemic treatment that you have. So you have your acitretin, cyclosporin, apremilast, methotrexate, and then biologics. You have your MABs, and then your etanercept. We're going to talk about these. So here is where I want to start, unless my patient is very severe, or I tell you it's covering like a huge percentage of their body, then we might need to have that oral systemic exposure, right? So then we could potentially end up over here. Oral, these are injectables that they would have to do, okay? So again, just put mild when we're talking about our topicals, so mild. We can also combine these and layer them. Most of the time, your patients aren't just going to respond to that steroid. They're going to need you to tackle it with other things as well. So most of the time, you will see your patients with combos. So mild, you can do the topical steroid. I don't want to leave them on a steroid for a long time, but they may have that flare for a long time with their psoriasis. So that's where you can see I can like alternate these things and try to say, hey, let me use this one over this one. Okay, we use this one for 6 weeks now. Let me try to use this one. Kind of playing around with what you're going to put your patient on. Test-wise, know that you can use a steroid, okay, and that you can alternate with any of these. When you look at this, your efficacy is increasing as your potency increases, but sometimes that then will shorten how long we can use the medication, okay? The potency dictates how long I can have something on board. So always keep that in mind as that potency increases. Yes, I'm getting a better response, but I'm also shortening how long I can use the medication for, which may not always be good. You have that HPA axis suppression, you have the atrophy that can occur the longer they're using it, all the side effects that we talked about with our steroids on the previous lecture, and we'll talk about a steroid lecture in itself tomorrow. Lower potency areas, we want to put those in those thin areas, our growing areas, underarms, sometimes on the face. We like to do our lower potency. The higher potency are the ones that will cause more of that atrophy and that HPA axis suppression, and will absorb a lot of it in our thinner skin. So limit the use of your very high potency agents to 2 to 4 weeks. When we go over our steroid lecture, you're going to see this, but we want to say, hey, if I'm giving them a very high potency, also if it's a huge area, I need to probably be on that 2-week end. If it's a smaller area, I may be able to push it to the 4 weeks, okay? So yes, a huge range, but it's because it varies depending on how that patient appears. It's very individualized when we're treating this. Coal tar. Coal tar is not very commonly used. It's not as effective, number one. Also, it stinks. It's messy when you're putting it on. It's just not fantastic. It doesn't blend in with your skin or anything. It's just very thick. So when you look at your coal tar, less effective. Again, just put mild on here. I won't expect for you to do the mild to moderate, mild. And then this is a good option because it's over the counter, so if I don't have insurance, something like that, this is a cheap option for me to try to use. Because remember, I can't go and get a steroid outside of a very low potency steroid over the counter. It's probably not going to be as effective for me. So this is a good option for someone if they didn't have enough money to have a prescription or a doctor's visit. But again, not as effective. Adverse effects, same things that we've been seeing, was kind of like our benzoyl peroxide. Instead of like bleaching things, this stains things. So I give them the same thing except a little opposite. I'll tell them, hey, get a darker colored pillowcase because it's going to stain whatever you come into contact with, or your sheets, what have you, because it doesn't necessarily mean that this is just on the face. It could be any part of their body. So I make sure that they have on something that they don't mind getting discolored. And I already told you about this. It smells carcinogenic in animals. Do I really want to use it in a human? Probably not. But again, this is the longer that they're using it, the more likely they are to have this happen. But we haven't had any cases yet. Potentially carcinogenic in humans. Your vitamin D3 analogs. When we look at this, calcitriol is what we're looking at as our active form that goes out in the body and actually does what we need it to do. When you're looking at this, it is going to regulate your calcium to promote growth and help with that remodeling of the bone, right? We said that this was in that homeostasis of the bone when y'all talked about osteoporosis. But we're looking at the effectiveness or what it's actually doing in psoriasis, we don't know. We know that it works, okay? So when you're looking at these, we have different options that you have. Your calcitriol, your calcipotriol, and your calcipotriene, and then the combination of your calcipotriene with your betamethasone, which was the steroid. The one that you'll see typically used is going to be your calcitriol, which is this one, because it's not as irritating for a lot of the patients. And then depending on how thick their plaque is, these ointments may be very good for them to kind of moisturize and soften that skin in that area, okay? So kind of, again, remember your vehicles and what you're picking. Our clinical use, mild as monotherapy, but if it's moderate, you're going to be using these in moderate to severe. You're going to be using these in combination with other medications, right? So we're going to be double-pronged, kind of trying to attack the disease in those plaque formations. If I combine it with that betamethasone, which is that steroid, that's where I can see the increased response, because now this is also going to be helping me with that inflammation that the patient is experiencing, right? So again, because we're adding that steroid, we're limiting how long we can use it. So it's going to be intermittent use, and hopefully that flare is going to be resolved by the time we have to pull off that combo with the steroid. Slow onset, most of the time you're using it for maintenance. We're not going to use it with any of our acids or our stuff that we said ended in, because it can inactivate the medication. So now that's a drug-to-drug interaction, right? Because now I have inactivated my topical vitamin D3 analog, which I know is helping me with my plaques, right? And decreasing the growth rate of my plaques. When you're using this, You see how it says reasonable to alternate steroid in the morning and calcitriol or your calcipotriene in the evening. So, in a case where you don't want to have them using both of these things at the same time, or for whatever reason they cannot tolerate them both at the same time, and you want a longer period of coverage, you can alternate how you're doing that. We're doing the steroid in the morning, why? Why not at night? Yes, right? So remember, our cortisol levels, everything are higher in the morning, so that's why I'm giving my steroid in the morning versus giving my vitamin D3 analog in the morning, okay? So same concepts, remember them as you're going throughout, because it can help you kind of notice some stuff. Your calcitriol, your calcipotriene, you see that they have very similar efficacy, but like I told you previously, your calcitriol is the one that has less adverse effects, less irritation, so that's why we typically will use that one more. Looking at your adverse effects, that irritation that could potentially occur, looking at your patients who have low levels of calcium, making sure that those levels are corrected. It's a topical, you don't see a whole lot of issues with it, but it could be something that you could potentially see. So just make sure that you're monitoring their calcium levels. And then again, looking at the fact that you have your combo with the steroid. So again, HPA axis suppression possible to occur. We like to give this in the morning because we're trying to mimic that natural cycle. And then making sure that you're not using it in those thinner areas, because now I have that betamethasone on there. When we talk about the strengths, this will make sense as to why we don't want to use it in those more sensitive areas. Tazarotene or your Tazarac, again, topical retinoid that we have, vitamin A derivative. We've seen this before, this drug. Again, just making sure that we're decreasing the plaques that your patient has is what we're trying to do. Mild, we already talked about this when we were looking at acne. And then here, please pay attention to this because it's the same thing when we talk about our steroids and the areas that we need to avoid become very important. So because of the strength and the irritation that could potentially occur, we want to make sure that we're avoiding it in folds, in the genital area, or even in the skin. What that means, if I have a heavier person or someone, even like under someone's breast, right, that is a skin fold. If you have someone who's heavier and they have folds, like in their skin, make sure that they're not just putting it in there because that's also a form of occlusion, okay? It's a natural occlusion that's happening because now my skin isn't breathing the normal way, okay? So please be careful with that. The benefits after they stop taking this medication, it lasts for a pretty long time, so 3 months after they even stop it. But again, remember your T's, those were teratogenic. So this one is one of the ones that is teratogenic as well, okay? Risk for teratogenicity. We'll start here tomorrow, okay?